Greetings. My name is Dr. Jay Kennedy, and I'm here today with Dr. Jean Phillipe Duverseau from Haiti, the city of Port-au-Prince?
From Port-au-Prince, Haiti.
Port-au-Prince, Haiti. And we're going to have just a sort of a short discussion regarding both the situation in Haiti and the kind of trauma work that you've had to deal with since the earthquake, as well as how decompression has fit into the practice of a orthopedic surgeon, and why you chose to consider using decompression, non-surgical decompression. So maybe you could just give us a little recap, let's say, of the situation in Haiti, what you've had to sort of struggle through in the last year. It's been almost a year and a half now since the...
It's a year, almost. It was a year and 2 months now from the earthquake, and after the quake, we lost all our hospital facilities, and it was very hard for us to treat patients. So we had help from the States, from Europe, and from around the world, and it was very tough to deal with that situation.
Did people die in the hospitals during the quake? I mean, they weren't able to evacuate the hospitals.
They were unable to evacuate the hospital, and a lot of hospitals collapsed. And
so there was no place to put the patients that were evacuated.
No, the patients were evacuated. I mean, few patients who were evacuated, they were put in the streets, and we had a hospital in the streets.
And so literally, you were doing surgery on patients on the streets, in what would be considered to be unsanitary, not fully unsanitary, but not sanitized conditions.
It's not sanitized. I mean, the streets are sanitized.
And you were seeing trauma such as broken bones?
Broken bones and amputation and...
Good grief.
Name it.
Name it. Now, most of the... would you say the hospitals, to a great degree, focus on, at least in the orthopedic wings, do they focus on mainly trauma-induced problems? Now, not from the earthquake, but prior to that, was it mainly broken bones people would come to the orthopedic wing, or were they suffering with back pain the way we, if you go to a hospital in New York, 30% of the people go in there and say, I got this back pain, it's sciatic. Yeah. They're overweight, they're out of shape, and so forth. Was that a common finding as well?
Yeah, it's the number one cause of consultation at an orthopedic clinic in Port-au-Prince. It's low back pain.
Chronic low back pain, without sciatic.
With or without sciatic.
And most of the time, when you do your analysis, your MRIs and so forth, you're finding the same features that everyone finds. Herniated discs.
Herniated discs, bulging, or protrusion. Yep.
And degeneration, just like all of us.
Right.
Now, is the population different in terms of its demographics? Would the people be younger, older?
They're different. I mean, outside of Port-au-Prince, you have people with large bone, large cervical and lumbar bones, because they have actual loading. They put stuff on their head, and in Port-au-Prince, it's another population.
Right, more like Western cultures.
Like Western cultures.
So when you look at the people outside of the cities, you're looking at people that, generally speaking, are workers, perhaps day laborers or heavy laborers, and they also walk a lot, which to me is interesting, because I've seen studies that suggest cultures that walk long distances. An famous orthopedic in New York mentioned in Prevention magazine recently, he said, this country doesn't suffer from a back pain and an obesity epidemic because of too much food. It suffers it because of too much gasoline. They drive too much.
Right.
So, I mean, when you look at the populations outside the city that don't drive sit,
they work a lot.
They have bigger bones based on that enlargement from Wolff's Law, but they also have less pain.
Exactly.
And do they live as long?
Well, not really.
Because of infections?
Because of lack of a lot of stuff.
Now, getting to the ideas of decompression.
Right.
Surgical interventions focus on decompressing a disc from a surgical profile. When you thought about non-surgical decompression, what were your thinking? How were you?
I used to perform surgery for patients with a couple of neurosurgical friends, also in Haiti, And last year I got a patient. I was supposed to do surgery for her. And she told me that she's going to the States. And she went to Miami. And 4 months after, she came back pain-free. I said, how come you pain-free? Have you been, you had surgery in the States? She said, no, I had decompression. I said, what can she tell me? Well, I went to see a chiropractor. And, I mean, an orthopedic surgeon first, and then a chiropractor. And she had spinal decompression. I said, well, can I see the last MRI? She showed me the last MRI, and there was a modification of what she had 4 months prior to this. I said, well, what technique? She gave me the phone number of a guy. I called him. He talked to me about the KDT, and my sons, who lives in the States, they went to see the boss, Mr. Misko, and they told me that Dad, it sounds good, it's good, and I said, okay, why not? And I went for it, and I start last November the decompression for my patient, and they're happy.
They're happy.
They're happy. I got good results so far.
Now, there's always. We always say to everybody that there's always an indication for surgery at some point because of the limitations of healing. So you still see the slip through, or will you typically fail with the non-surgical approach first, or are there some patients you just say, that's not going to work, you need surgery?
No. Since last November, I changed the protocol at my office. Well, first of all, I mean, you got it. I start physical therapy. Then I make peridural infiltration, and after that, decompression and laser.
Oh, so you're doing the protocol to a great degree that we all sort of have funneled ourselves towards. We say the same thing, that laser is a potent help in the healing process.
And hence the healing process.
Now, the physical therapists that you deal with in Haiti, are they also approaching in a similar way, or do they sort of bypass the use of lasers and you don't find a lot of them using traction?
I'm the only one using laser.
The only one using laser.
The laser in Haiti, it's new.
Right.
It's new, and they're happy using it.
And they also, traction is not a specific common, you don't find it typically?
I mean, at my office, we do have the only decompression device in Haiti.
In all of Haiti. That's fantastic.
Fortunately, but it's...
Yeah, exactly. You said that you're only one of 40 orthopedic surgeons
in
the country.
43 actually. We were 53, but we lost 10 orthopedic surgeons in the quake, and actually 43.
And the one chiropractor also passed away in the earthquake.
Yeah, he passed away, unfortunately.
Is chiropractic licensed in Haiti?
No.
So
we don't have any chiropractic school in Haiti. The only one actually working down there has been trained in the States.
Sure. But when he comes to Haiti, does he practice as a chiropractor, and would people consider him to be a doctor of chiropractic, and they would be allowed to ask for money and cash?
Yep.
And the insurance industry in that country is minimal. Like, will decompression or physical therapy be covered by an insurance carrier?
Actually, I'm fighting with them. Fighting because they do not know decompression. So when I start decompression, I ask them, I got a new technique, and you're gonna have to deal with it. They say, well, no. I say, okay. So when they find, I was lucky. I was lucky because last December, the wife of one of the insurance boss in Haiti, she came to see me with low back pain, and I treat her with decompression and laser, and she's happy now. And I say, hey, you see the result? So we're gonna have to talk business. Say, well, okay.
It's funny, we see that a lot. If you can positively influence somebody in an authoritative role, they will tend to say, okay, let's look into this a little bit more thoroughly. My other question is, when you're dealing with decompression non-surgically, do you find that there is a point where you just recognize it's not going to work? And if so, is there a patient class that you've found, I can try it, but I just don't think it pans out? Or is it kind of working across a whole wide swath of people?
Yes. I have one patient in mind, and it didn't work. Why? Because she has bulging, she has herniated disc, and she has also osteoarthritis.
Okay.
With facet syndrome, and I had to perform surgery for her.
And your surgery was surgical decompression or fusion?
It was fusion.
Now, just out of curiosity, because this is coming out in studies that I've read recently, the better the fusion, the more thorough the fusion, and the less what they term inducible motion viewed after the surgeries, it appears as though that gives the best response. That's right. So the better the fusion, you got
the best response.
So if you're looking at like a focal one segment disc herniation, do you still prefer the thought of doing fusion there, or would you also go in and just do a one-level discectomy and be done with it? And see?
No, I prefer to make laminectomy. Laminectomy and then fusion. Then fusion.
And so over the course of time, that's what appears to be necessary. So in that population of people, you're still seeing those success from the beginning. As you look at those patients that end up in surgery, there's still some that don't need surgery. There's still many that seem to have a reduction. And have you seen any correlation to post-MRIs after decompression, non-surgical, reductions, or might the same patient show a focal hernia before intervention, no pain, in the same exact herniation? I mean, do you see that as well, or is there a change in the MRIs?
I got change in the MRIs. I got change. And actually, I'm waiting for one MRI because we don't have MRI in Haiti.
Oh.
We have to do it in DR, Dominican Republic, or in the States.
Is that right? Yeah, no MRIs?
We lost them. During the quake, we had two MRIs, and we lost them during the quake.
Now, that would be, in my opinion, almost a crippling. How in the world would you recognize? Because you can't do myelograms. You have a CAT scans?
We have CAT scans.
You have CAT scans.
We have two CAT scans, but to make an MRI, you have to go to DR. It's, one day.
Okay, so an MRI is obviously a necessity.
Yep, a necessity. Yep.
But not for the non-surgical. You don't necessarily need it for non-surgical.
Non-surgical, no.
And have you found any contraindications as of this minimal amount of time that you've been doing the non-surgical? Have you found any as an orthopedic surgeon contraindicated for the traction? Have you said to yourself, I tried that and it caused trouble? Has anything stood out that there's a problem?
Not really. Not really. I was wondering as a patient. It's a guy with metastatic tumor from his prostate. And I was wondering, am I going to do it? Am I not? And it was the only indication for me.
Right.
Because the bone was very weak, so I said no. But otherwise, no.
Otherwise, no. And you've taken the course that we offer for the training.
Yeah.
We've tried to, as I say to as many people as I can, we've tried to not bias the course towards equipment or towards specific agenda.
Right.
Do you feel that the course will give you some guidance in your approach?
Yes, I know how to use the table now. I used to use it, but actually it's very versatile, and it's I know how to do it. It's a great course, and I'm going to invite a couple of friends from Haiti to come over and to have it.
Cool. It's excellent.
And you're a great teacher too.
Oh, well, I appreciate that. Thank you. Now, are there physiatrists in Haiti? Is physiatry structured?
Yep. We have two physiatrists and two ladies, and yes, they're working there.
And do they ever give any discussions regarding the use of traction? Because I know that their physical medicine...
No, unfortunately, no.
They mainly focus on injections and like they do in the States.
Yeah.
Not a lot of that. Okay, well...
Thank you very much.
Yes, thank you very much. I really appreciate your time.